Good afternoon, everyone. Good morning to those of you on the West Coast. We will be starting in Module 2 in just a few minutes, about a minute or so, to allow some other folks to join us. But we're excited to get started today, so stay tuned and we'll begin shortly. All right, hi everyone, and thank you for joining us for the second module in our Learning Collaborative, Developing Cross-Sector Partnerships to Improve Health Outcomes. Today's module will focus on gathering information about your patient population and mapping potential partners in your community to help build the kind of programs we heard about in Module 1. And speaking of Module 1, I just want to reintroduce Saki and Christine. Saki from the National Center for Health and Public Housing, Christine from the National Center for Equitable Care for Elders. And Saki, do you want to just give us a brief recap of Module 1 and maybe remind folks what we talked about?
Sure. Thanks so much to you, Emily, and to everyone that's joining again. Last week we had a really great presentation from Sue Vega from Olivio Medical Center who discussed their senior housing program that the health center runs and the interesting public and private partnership that created the ability for the medical center to work with some nonprofits to create this housing building for seniors. And Sue also mentioned a lot of the other partnerships that they work on at the health center to improve access to care for senior patients. Sue participated in a case study publication that we at the National Center for Health and Public Housing developed earlier this year. And you can find out more information about the different programs that are available at some of the health centers through the link to the resource that's available through Slack, and also I think in an email that Emily has sent to you guys earlier. And we did have some good questions and feedback, but I just wanted to reach out to all of you guys and let you know if you do have a question, a follow-up question from last week that you'd like to submit to us either through the questions box or through Slack or in a personal email, feel free to do that. We'd like to spend a lot of our time on the last Learning Collaborative of this series, really going through case studies from you all, so that all of your challenges can be addressed and you have the ability to hear from your peers about what is working in their communities. So you can do that either to an email to any of us that are organizing this Learning Collaborative or through Slack. And that's it. Thank you.
Great. Thanks, Saki. Christine, anything you wanted to add?
No, just looking forward to today's session. And as Saki had mentioned, if anyone has any questions, to please feel free to use either the chat box or the question box. Thank you.
Great, thank you both. And speaking of questions, please feel free to use the question box to type in your questions anytime throughout the presentation. We're also going to be using the question pane to facilitate an activity that we're going to do. So please just have that available. If you need it to be a little bigger on your screen, I know sometimes it's a little hard to read as they come through, but you can actually expand it. So next to the questions, or next to the word questions on the right-hand side, there's a little X to X out of it, but you can also expand it by clicking that little box with the arrow pointing up to the left. So you can expand that and have that bigger on your screen. And also I'm going to have Hayden, our extra special webinar guru here, put our email addresses in the chat box for you so that you can have those as well, just in case you aren't on Slack to ask questions. Speaking of Slack, Some good segues. Please engage with us and your fellow learners on Slack. We would love to hear from you and continue discussion after each module. So please feel free to use Slack to share some of your organization's promising practices, questions, or ideas, like Saki said. And then we will kind of engage with that during the fourth module and use the fourth module as sort of a case study workshop, if you will. So here's a reminder of our Learning Collaborative schedule. Today is our second module, and you can find the recording from the first module linked on the slide. The slides are available in your handouts pane as well, so you can go ahead and download those so that you can have them available. Our next two modules will take place on the 20th and the 27th, respectively. So we wanted to actually start out with a quick poll just to get everybody kind of engaged. We want to just sort of see if Slack is useful or helpful to you. I know some of you may not be on it, and then others have been using it just to get some updates. So we just want to get a sense of whether it's been useful. So just go ahead and take a few seconds to do that poll. Okay, great. So we got some mixed results there. So some not super useful, somewhat, and yes. So hopefully, and I really would love your feedback about how to make this a useful platform for you all. GoToWebinar kind of limits our ability to interact with each other. So really want to use Slack as a way to kind of engage with one another throughout the Learning Collaborative, maybe share contact information with your fellow learners, maybe connect with folks. So feel free to send me an email, and Hayden will send our emails in the chat, and you can kind of give me any suggestions that you think would be helpful. Okay, so with that, let's dive into today's presentation. So during this module, we're going to talk about some of the data trends we see for older adults, as well as data sources your health center can use to learn about the population you serve. Later, I'm going to be joined by Jillian Bird, who's our nurse training manager here at NNCC. She's going to discuss mapping your medical neighborhood, and she'll also walk us through an activity around the case study I sent out this week. The case study can also be found in your handouts pane. So last week, Saki and Christine shared some health and demographic information about residents of public housing and older adults. And today we're going to take a deeper dive into some of the trends we're seeing for older adults, as well as the social determinants of health that intersect with this population. So Saki showed us this demographic information from HUD, which breaks down the population statistics for HUD-assisted individuals in the United States. Not only does this graphic help illustrate some relevant demographics about residents' public housing, but it also demonstrates one of the key concepts about social determinants of health. Our patients are a part of many different groups and populations and can experience limitations based on any number of characteristics that make up their identity. It's important to note that 17% of public housing residents are elderly. So during this learning collaborative, we'll want to think about the needs of patients who intersect these and other groups. Christine in Module 1 shared some health trends about older adults, but it might be useful to take a look at some of the demographic data about older adults and think about how these trends might influence healthcare delivery in the future. The older adult population, age 65 and older in the US, has been growing steadily for 100 years and will continue to grow based on current life expectancies and the sizes of cohorts who are aging into the older adult category. Within 10 to 15 years, demographers expect there to be more older adults than children, most of them aging in place. In addition, those over 85, a group that some demographers call the oldest old, and which used to be a very small group, is also growing. Although right now only 3% of public housing householder or spouses are 85 or older, that number will also increase. Life expectancy of those who reach 85 is increasing, and cohort sizes are also. And you can find the sources for this information at the bottom left hand of your screen. Earlier, I talked about intersectionality and how we all represent different groups as part of our identity and experiences. And we can see this play out in this slide as well. Housing is an important social determinant of health, and unstable housing or homelessness is highly correlated with poor health and high use of emergency room resources. There's an emerging crisis in homelessness among older adults. Researchers recently used data from LA, Boston, and New York to forecast shelter use by persons 65 or older through 2030. And the research showed that older adults age 65 and older seeking shelter services are expected to increase 2.5 times or more in these metropolitan areas. So why is homelessness important to think about for public housing? Isn't this a different group of people? In fact, we actually find that many older adults in public housing may have experienced some period of homelessness or unstable housing. And increasingly, municipalities are trying to accommodate older adults in public housing instead of shelters to reduce medical costs. And individuals who have experienced homelessness or even just unstable housing in the recent past may have ongoing worse health-related experiences than those who do not experience that. Social connectedness is another important SDOH, and it has several dimensions. Who someone lives with is related to both emotional and practical concerns related to social support. So as Saki mentioned last time, and we recapped earlier, 59% of public housing residents are female. Overall, more women than men live alone, and more men live with a spouse or partner. Although we don't have more specific data for older women in public housing, 70% of heads of households in public housing are women. So many older women in public housing are also likely the only adult in the household. So why this emphasis on living alone and gender? First, because being the only adult in the household has some implications for seeking medical care. Older adults who live alone are more likely to go to the ER than peers who do not live alone. When using the healthcare system proactively, older adults who live alone are more likely to need assistance navigating the healthcare system, especially when it comes to specialist care or access to testing like mammograms, colonoscopies, or MRIs. Older adults living in public housing are more likely than the general population to need navigation and transportation help because they are more likely to be women and the only adult. Many older adults living alone are very concerned about what will happen as they age and are very concerned about the accessibility of their living space, transportation, and the ability to shop and prepare food. And that's sort of something that we'll see in the case study that we'll discuss later. Lower income adults and those who live alone are more worried than other older adults. And second, living alone can increase the risk of loneliness and or isolation, both of which are health risks for older adults. So along those lines, a recent AARP survey found that more low-income adults reported they were frequently or often lonely, with about 1 in 3 of low-income adults reporting this compared to about 1 in 6 among higher-income older adults. Loneliness and isolation are important social determinants of health and are associated with greater risk of cognitive decline, depression, and heart disease. Isolation may be particularly severe for older adults who live alone in neighborhoods that have high rates of crime or feature built environments in disrepair, according to a study that was done including many residents of public housing. Food insecurity is another important issue with SDOH. So nutrition, as we know, is an important aspect of health. So access to appropriate nutrition is crucial, especially for older adults with chronic conditions. In this AARP survey that we're citing here, food insecurity is quite common among older adults, including those a little younger than 65. Why does this matter so much to older adults aged 65 and up if their access to food improves? There is increasing evidence that individuals who have experienced food insecurity are more likely to choose food that give a sense of satiety over nutrient density, which may go against state-of-the-art nutrition management for chronic health conditions. So what do these trends mean for us as we provide care to patients in the community? It comes back to the social determinants of health and the ways in which a patient's lived experience impacts their health outcomes. We've talked about SDOH throughout this module and touched on it last week as well, but I think this graphic from the Institute for Clinical Systems Improvement really captures the themes we're discussing. A person isn't defined by one of their characteristics, but all of them. As we'll see in our case study later, patients present us with a variety of economic, social, health, and physical factors that influence their well-being. I made a note on this slide about the effect of a patient's neighborhood, has on their well-being. And that's certainly something we'll want to keep in mind when discussing residents of public housing. Many seniors are aging in place, and the place in question has a huge factor on SDOH. So with that, we want to do another poll and just kind of get a sense from folks, what are some neighborhood characteristics that affect an individual's health? And go ahead and just answer the poll within the next couple seconds or so. I think everyone sort of got the idea of this poll, which really is, yeah, to say it is all of the above. And we're going to discuss some of those adverse neighborhood conditions in the next couple slides. So thanks for completing that poll. So I won't go over this chart in detail, but you can find the website for this on your slides if you want to look at it closer. But it provides a helpful breakdown of some of the neighborhood features that can contribute to a patient's health as they age in place. So we'll talk about some of these features in our case study as well. What are some of the adverse neighborhood conditions that our patients might experience, and how can your organization determine whether patients might be affected by them? All of you, I think, are aware of what those adverse conditions are, as we saw on the poll, but kind of want to dive into them a little bit. Median income can actually be a marker of neighborhood disadvantages. So if you have access to income data for your area, you may be able to make an inference about the conditions of that area, or at least do some additional exploring about the neighborhoods your patients come from. We also know that food access, safety, and walkability all affect a patient's health and are linked to their lived environment. Your health center may screen patients about their perceived safety as well as their access to food and outdoor space. These screenings and some select health outcomes might indicate adverse neighborhood conditions. Finally, HUD data also shows us that a majority of residents of public housing are part of minority or racial or ethnic groups. So race and ethnicity are critical components of SDOH and are especially influential for older adults who may have experienced bias and discrimination based on race over a lifetime. So given all of this information, which is a lot of information, we might ask ourselves the following questions. What are the highest concentrations of older adults living in public housing in your community? What is the broader demographic makeup of the community? And what is the median income of neighborhoods where our patients live? So we want to provide you with some resources, data resources that you may or may not be using right now at your organization. And again, these questions that we framed on the earlier slide, let me actually just switch back to that. So these questions will help us identify the sources of data that we can use to learn more about the community, but they can also help us think of organizations that may potentially be good partners for programs and services to benefit our patients. So while the national data we talked about is important to keep in mind, at the end of the day, we need to be able to speak to the needs of our community and the patients that we see on a daily basis. So many of you, again, may collect this information as part of your health center's needs assessment, in addition to patient feedback and other screenings. If not, there are some really great free resources out there that you can use to dive into these demographics. And we're going to go through just a couple of them before I turn it over to Jillian. So HUD is a great source for public housing data, as Saki had mentioned in Module 1, and it has both resident characteristics reports and information about local housing authorities. So a great way to look at potential partners. When you're looking at the HUD data, keep in mind that you need to filter for public housing among the programs to meet HRSA's definition of what constitutes public housing, which, for a reminder, is public housing, agency developed, owned, or assisted low-income housing, including mixed finance projects, but importantly excludes housing units with no public housing agency support other than Section 8 housing vouchers. So excluding Section 8, which, as we know, is a pretty big part of our public housing communities in our areas, but for HRSA's purposes, that is not included in their public housing data. UDS Mapper is also an extremely valuable data source, and I hope many of you use it at your health center. In UDS Mapper, you can enter your health center's address and see relevant demographics in your community, as well as the location of other healthcare providers and housing authorities and developments. The mapper's ability to identify other relevant organizations can also be really helpful when mapping your medical neighborhood, as Jillian will discuss later. So this slide kind of outlines some of the information you can find in UDS Mapper. You can quickly scan that. UDS Mapper is also always adding more information and usually offers free trainings that you can find in the Bureau of Primary Healthcare BIPIC Digest, if you subscribe to that, which I hope you all do. There's some great trainings in there. Another great source for information is Community Commons. This is a map of the Philadelphia area where NNCC is based from Community Commons, and you can use the Commons to make a variety of similar maps by census tract or block group for many census-related indicators, and at the county level for many more. So in this map, the darker the green, the higher the median income of a tract, the lighter the green, the lower. Community Commons is unique in having some food-related data sources as well. So I've listed some information here that you can find in Community Commons, but soon you'll be able to run community indicator reports on custom areas, which will be really helpful if you need specific information about your region. County Health Profiles also has a great site that lets you explore county-level health rankings and data. So I especially like how comprehensive this site is. County health rankings are available for every county and compile information on health outcomes, including mortality, low birth weight, poor health days, distress, diabetes prevalence, health behaviors, so alcohol use, exercise, food environment, and insecurity, access to care variables, levels of uninsured, patient-provider ratios, things like that, physical environmental factors, including air pollution, drinking water violations, housing problems, et cetera, and then other social determinants of health factors, which I don't think are listed here, but it is pretty comprehensive and includes educational attainment, unemployment, crime, poverty, and things like that. So really extremely helpful on the county level. So this might be a little too broad for you to look sort of in the community, but it does provide a lot of interesting indicators in one place and can help answer maybe some questions that you might have. So finally, I added the Build Healthy Places Network website as a resource. This site links to several different mapping related resources to explore. One of them listed here, for example, is the Distressed Communities Index that you can see there, and that provides a single assessment of community economic well-being and is available as small as the zip code level. So really some granular level data for you. And here are some just additional resources that you can explore if you find that useful. But now that we've really talked about the demographics and characteristics of our patients' communities, Jillian is going to kind of bridge that to how we engage potential partners with this information and how we can maybe conduct a similar analysis of potential partners in our community. Thanks, and I'll turn it over to Jillian.
Thank you, Emily. And thanks to everybody for joining us today. I'm happy to be with you today. So the next part of our presentation will focus on how to identify community partners that can help meet the needs of the population you identify through the sources Emily just discussed with us. And we are going to discuss some key elements of mapping a medical neighborhood and how it can inform your practice, including identifying potential neighbors, answering why constructing partnerships is important in care delivery, understanding care mapping as a tool, and sharing a few strategies for establishing partnerships. So our goal today is to cover the following. Identify key components of the medical neighborhood and how you can be situated within it. Identify existing barriers to achieving a well-functioning medical neighborhood. Provide approaches and tools useful to creating a well-functioning neighborhood. So as a patient-centered primary care collaborative defines a medical neighborhood as a clinical community partnership that includes the medical and social supports necessary to enhance health. This includes the medical home serving as the patient's primary hub and the coordinator of healthcare delivery. The goals of high-functioning medical homes include collaborating with these various medical neighbors to encourage the flow of information across and between clinicians and patients, to include specialists, hospitals, home health, long-term care, and other clinical providers. So according to the Agency for Healthcare Research and Quality, the patient-centered medical home and the surrounding medical neighborhood can focus on meeting the needs of the individual patient, but also incorporate aspects of population health and overall community health needs in its objectives. And as we move forward with our activity, we will be looking at the case study and working on a very individual basis. But the idea is to replicate this as a population health driver for connecting across the medical community. The primary purpose of the well-functioning medical neighborhood is the delivery of coordinated care. And at its core, a well-functioning medical neighborhood requires basic communication and coordination functions. And this requires regular communication, collaboration, and shared decision-making across various actors in the system. Ideally, the neighborhood encourages the population health and shares resources within a community. So including infrastructural support such as health information technology and performance measurements. But starting with the basics and where the most focus needs to occur is, for example, getting hospitals to send the primary care clinicians reports of the patients admitted, or ensuring that primary care clinicians are making appropriate referrals and the follow-up with specialists are happening with providing the background information and also being updated on the clinical treatment plan and understanding what goals are in place for consultation. So we're going to do a brief poll, a couple of polls. Please take a moment to answer the following. Do you know whether your patients are living in public housing? We'll just take a minute to get a number of answers before we look at our results. Okay, so a little bit of uncertainty, it seems, or certain knowledge that yes, in fact, we've got almost half of the group saying that they do know that their patients are living within public housing, and a good portion that are unsure. Our next poll is to look at or acknowledge that many of you are already in some type of participation in your medical neighborhood, and we just want to know how many of you are already involved with certain of these organizations, including faith-based organizations, assisted living, community centers, food banks, for example, senior community centers would be one. Okay. So already building relationships with, for example, we have schools, quite a few, 100% with food banks, which is outstanding to address food insecurities. Strong coordination between schools as well as community centers. Half of you are connecting with faith-based organizations such as churches, and then also a portion with assisted living. That's great. So you already can draw on your expertise in this area. Okay. So today we'll be looking more closely at this concept and how to begin creating a medical neighborhood from both the patient and population perspective. So how you define the medical neighborhood, who is included, and remember this is not about proximity so much as who we want to be involved with the care of a patient or a population. And when we think about the medical neighborhood, let's consider and think about who our neighbors are. So in looking at this right now, if you could use your chat box to acknowledge who might be missing from this list of neighbors.
So yeah, just use your question pane to kind of type in out of this list here, as Jillian said, who might you add to this this sort of circular chart.
Okay, we're having one reply here with schools. We did just acknowledge before with food banks, perhaps fire or police if they're really integrated into the neighborhood. Oh, the question was, when looking at this diagram, who might be other medical neighbors that are missing for serving a patient in a community? There also might be different treatment providers across specialties or across sites or locations. Yes, transportation is one to consider. We have schools again. Great, thank you. So here on this slide, we're looking at outcomes, proposed outcomes for the well-functioning medical neighborhood, and they're falling all the way to the right side of the slide here. And the short-term outcomes that you can begin to identify when the medical neighborhood is really well-functioning would be an acknowledged improvement in care coordination, an improvement in patient safety, and as well as the patient experience, which is, as we all know, very important for maintaining that relationship with the provider. And then long term, we have improved clinical outcomes, reduced costs through reduction of duplication and waste, and improved population health management. So the next slide, we'll look at the possible barriers to creating the medical neighborhood. Many of you may have already encountered some of these. For example, no or few financial incentives for supporting care coordination in a medical neighborhood, the lack of staff or time for investing in that level of coordination at the practice level or across the community, limited primary care clinician involvement in the inpatient care, and sometimes complete lack of knowledge of the inpatient status of patients. We often have fragmented, very diverse services rather than an integrated delivery system. Also, the financial integration across providers typically is non-existent or sporadic, as well as the health IT infrastructures and interoperability. So, many of us are functioning in what feels like silos without that support infrastructurally. Also, the complexity of coordination for patients with high levels of needs can seem overwhelming, or there's a high need for referrals, and often patients are self-referring, and the provider, the primary care clinician, is unaware of who the patient is working with outside of their primary practice. And then we also have these misperceptions regarding HIPAA provisions and how information is allowed to be shared. Okay. So to better understand this, we'll start with a very simple concept of care mapping. And this is literally mapping out all the parties involved in caring for a person or population. This requires thinking about all the possible neighbors, many of whom we just covered, and trying to connect them in a map, so to speak. The result is a comprehensive snapshot of medical and social needs and who is addressing those needs. And as you literally map it out, you may find it illustrates many subsets of your high-risk population. And when done with an individual patient, it is a great way to activate the patient in their care. So you can use a care map with a patient, let them collaborate with you, and let them name the other providers that are involved in their care. And it becomes a tool to help everyone, clinicians and patients. They begin to work from the same knowledge and craft care plans together. And when the patient, for example, if this is a child, it may not be relevant always, but you use that with the entire family, or in some cases, elders need family involvement with coordination of care. So you involve the entire family, and this gets everybody on the same page. And once you do this with one individual, the idea then is to set the stage for a population medical neighborhood. You can then begin quickly identify the needs of an individual because you've already mapped this out with one, it can duplicate it with many. So the example we have for you here to look at is a care map for a child with special needs. And again, this can be translated appropriately to any patient, including older adults living in public housing. So the family is in the center, our patient and their immediate support system is in the center. And the branches of this care map identify who is involved in the social and medical supports for this family. And already we can see some of the things we've named and many others that we didn't. So we talked about transportation already. There's specialty hospitals listed here, really personal support systems, the legal and financial supports, the community and recreation, advocacy and leadership, and then sort of occupational therapy or developmental assistance. The immediate primary care clinicians are listed. So this gives you a sense of how care mapping looks when it's laid out on paper. Again, the elements of the care map are to create sort of a circle and then branch out, connecting the primary support structures for that person. And one way to think about, as we move more and more into technology, some of these could be incorporated into your electronic health records. They might even have GPS location because, again, it's not always about proximity, but about really what's working for the patient within their community. So thinking creatively about the format too can be helpful. And again, so the elements of the care map is to place the patient and family at the center, recognizing that this is a living document and that it will shift over time, considering the social determinants of health, as we have been discussing already in this session. And then again, this circular chart, I already talked about this, incorporating it into EMR, mapping out the physical locations. This could be something that you're handing off to your patient at checkout so that they know where to find these things. And if they're even using smartphones, for example, they can have them recorded in their phones. So we'll work now on an activity looking at the medical neighborhood. We'll start with this care map concept and work with our case study, which is Mrs. Riviera. And she is a patient at United Health Center, which is a federally qualified health center in a large urban area. Mrs. Riviera is 73 years old and lives alone in a public housing building, which is a few blocks away from the health center. English is Mrs. Riviera's second language, and while she is able to see providers and staff at United who speak Spanish, sometimes she struggles to access services in her community that aren't available in her native language. Mrs. Riviera has been diagnosed with type 2 diabetes and also experiences some weight-related mobility issues. Even though the health center is only a few blocks away, Mrs. Riviera finds it difficult to attend appointments without help from a neighbor. And in the past, she has reported difficulty finding the types of foods recommended by her provider at the health center. Her diabetes is currently uncontrolled. Mrs. Riviera is an avid churchgoer, but is sometimes unable to attend services due to her limited mobility. She has also mentioned that it's difficult to find safe, accessible outdoor spaces for exercise. And Mrs. Riviera is a Medicare member. So now we have our blank slate and thinking about really tailoring this care map for Mrs. Riviera. You can use your question box to help us fill in the missing circles here.
Yeah, so we're going to try to notate your answers as we get them in from the question box. I'm going to use my pen, I believe. And what we want you to do as well is, I know we can kind of be pretty broad with this and say, church and things like that. Yeah, perfect. Thank you, Marisha. So if you can also kind of make a pretend that Mrs. Rivera lives in your city if you want, and kind of name a specific thing. Great. So let's try to add some of these to her care map here. Oh wait, this is not going to be. Actually, I think I can do this. I think I can do this way. Just give me a second here. So I'm going to add it this way so we can all see what we're doing here. So we said church was one of them. Another is interpreters. Great. Food bank and safe exercise areas. So that might be like a YMCA. Now, another thing we might want to consider with that is, if she's unable to, access that YMCA or something like that, maybe some kind of transportation arrangement. Great, so we have some transportation.
We have the specialists for diabetes management, podiatrists, for example, the Public Housing Authority. This is great, the elderly advocacy group. So a lot of municipalities have a division that's supported by the city that is addressing the needs of the elderly specific to that municipality. So in an urban area, clearly would be quite different than in something that would be more in a suburban or rural setting. Different type of escort type services are available. Sometimes home visiting is covered when you have certain diagnoses for short term. Also, there's Meals on Wheels when you have diagnoses or mobility concerns. Those can also be prescribed and can be utilized to help kind of bridge those food insecurity concerns. So this is great. So little by little, we're beginning to map out other ways and places that Mrs. Riviera can find support within her community that extends beyond her church. It extends beyond her primary care provider, and as well as her family. It extends beyond her family. So thank you everyone for doing that.
Yeah, and I just wanted to add, to Jillian's piece there is that, it's not just sort of sending Mrs. Rivera out into the community to access these services and sort of that's the end of her engagement with us. I think we really do see those outcomes translated back to us, as providers when we link patients with these services. We might see that her diabetes, her A1C level drops, for example, or her diet improves, things like that. So we really do see these outcomes translated back to us. It might not be immediate, but certainly this type of work really kind of does pay dividends in the end.
And if there were any final thoughts, we'll just do one last quick look at the questions box to make sure we didn't miss any last ones before we move on. All right, home visiting, great. Yes, the home visiting bilingual. And then we did have a question, are there escort type services that would go with her on walks? I think that's a great question and could really speak to a role that perhaps could be filled within faith-based organizations. If there are volunteers that are doing outreach, community outreach, where they might be coupled up with a member of a congregation or a synagogue or a church, so that they might have that type of program that's happening. And this would be only found out once we're actually reaching out to these potential neighbors and asking those types of questions. Exactly that.
And I was going to say too that one of the things that we haven't put up here are universities and academic institutions, which we really didn't mention before, but that can be a really great source. And I'm sure many health centers are using universities and colleges as, you know, have volunteers come in internships and things like that. So it might be that a local college has, you know, a volunteer program to do outreach with folks in the community and maybe go on walks and things like that. So that might be another great opportunity.
Okay, great. And we have some time for any final questions as well. So we've already had a lot of great sharing of ideas around care mapping. Really the idea when we have, like I was saying, built this out for an individual would be then to replicate this and almost program it out or kind of refine it to be applicable to a community or a population that you're managing. So if we have are there any other questions or thoughts to share? Perhaps there are some of you that have already been engaging with community neighbors that you would like to share how that's been working for you. We would also encourage, you know, formalizing some of those relationships over time where you establish verbal relationships, but then really formalize those over time. So Christine, I guess if I could turn this over to you, that would be great.
Thank you, Jillian. And so we actually had a question about 10 minutes earlier from Cindy, and her question was, are there existing guidelines for how and what data clinics can share with other partners? And Saki and her center actually just had done a webinar on electronic communication, and they discussed the issues related to privacy and sharing patient information. So she has a lot of great resources, and I think, Emily, if I'm correct, we can share those on Slack for everyone so that you have access to them.
Absolutely. So we'll put that in the resources channel on Slack, and we can make sure that everyone, and we'll also email it out with the recording for this as well if you're not on Slack. And I just want to say about Slack, and this is off topic a little bit, but if you're not getting notifications, you can change your notification style on either the desktop or the phone app so that you're getting those push notifications if you want to be, be notified when a channel is updated or something like that. But absolutely, we'll share those. And I know Christine and her team will be talking next week a little bit about that as well.
Sure. And I'd just like to add, as Christine mentioned, we had a webinar last week about sharing patient information and through electronic health records and through texting and patient portals. And this issue has come up. There is some guidance from HRSA on maintaining HIPAA compliance, but essentially it is, there's some information that you are able to release to other providers, but the most important thing is having consent from patients. And so there's some resources on how to obtain patient consent, and then the different types of information that's that you can share with whichever provider type. So it's like whether or not you're able to share health information with other providers, with other community organizations, and then with patients on their health issues. So it is kind of complicated, but there is a lot of guidance available. Thanks for the question.
Thanks.
And as Hayden mentioned, you can please type questions into the question tab, and we will make sure that we are looking at that and be able to answer your questions.
Yeah, and also just wanted to bring up Saki's point again about please share your case studies or promising practices in Slack with us so that we can kind of put those together for our 4th module, where we're really going to be just joining together to kind of workshop some of the questions and ideas that you all bring to the table. I'm not seeing any questions at the moment, but it is certainly still open. Meanwhile, as you all are busy typing away in the questions pane, I want to just remind you again to continue the discussion with us on Slack. And also, I think a lot of the questions that we have for this module are probably going to lead really well into the 3rd module, which will be presented by Christine and her team at the National Center for Equitable Care for Elders. And we're really going to talk about building and sustaining those partnerships. So, now that we've mapped the community partners that we might want to work with and understand, the population that we work in using some sources of data, how do we actually bridge that, and make that connection with partners? And then again, to Cindy's point, what's appropriate to share about our patients with those partners. So I think we'll delve into that a little bit more next week and hopefully answer some of those questions. Hayden earlier sent our email addresses through the chat box, so please feel free to use those to follow up with us with any questions, suggestions, thoughts. And again, you can certainly use Slack for that as well. But barring anything else, and if there are no other questions, we will go ahead and wrap up a few minutes early, which I'm sure no one will mind, to get a couple minutes back and get some coffee or a quick breath of fresh air. And we will share the recording and slides with you within about a day or so. But we really thank you all for joining us today, and thank you to Jillian for a great presentation about mapping our medical neighborhood. And we'll see you all next week. Thanks, everyone.
Thanks, everyone.